I am very excited to be speaking with you this evening on treatment options to consider when seizures persist despite medication. So, a brief introduction to epilepsy treatment. Medical management is absolutely the first line treatment for seizure control in all individuals diagnosed with epilepsy. There are 39 different medications available approved for use in epilepsy. The way the FDA works in the United States is once a medication gets approved, it tends to keep its approval unless there are significant safety concerns, in which case that approval can be reconsidered. But new medications can be added to that. So it starts with just a few, and then over time, multiple accrue over years. So many of these are very old medications, first approved many, many years ago. Some of them are no longer used or used with decreasing frequency. And the most recent new addition was added in 2019. So this is a living, breathing, dynamic list of medications available for the use of treating seizures. Medication can eliminate seizure activity in approximately 7 out of every 10 patients living with epilepsy. So we're here to talk about what happens to the other 3 patients out of 10 who continue to have seizures despite being on sometimes multiple medications. So I'd like to briefly introduce this landmark paper published in the New England Journal of Medicine in 2000, titled "The Early Identification of Refractory Epilepsy." This is really the fundamental groundwork for understanding the rate of seizure control using medication in a large patient population. The study followed 525 subjects ranging in age from 9 to 93 years over a study period of 13 years. Among the 525 patients included in the analysis, 470 of those 525 were first started on seizure medication during the course of the trial. So the other patients had previously been on the medication and were captured by this broad net of analysis, but 470 patients were first started on seizure medication during the trial period. And of those 470 patients, about half became completely seizure-free following the starting the first seizure medication. Another 14% became seizure-free following the addition of a second or even third medication, but importantly, fewer than 3% became seizure-free after a trial of more than 3 medications. And it's very important to note that there was no significant difference between more established medications, or those older medications that have been around for a long time, and the newer medications. And the reason this matters is because we always think that we're waiting for that newest, best, greatest medication that's going to be the one that we've all been waiting for. And we really have multiple decades worth of data to tell us that that's not necessarily the case. There's just something in about 30% of people living with epilepsy that makes their seizures more difficult to control with medication. And they're the folks we're here to talk about what options are available for them this evening. So options for medication-resistant seizures, and this goes by a number of different titles, including medically refractory, treatment-resistant, medication-resistant. They're all ways of saying the same thing. It's basically just seizures that persist despite medication. So the first is diet therapy, and it's not necessarily the first in the order of which we would try them. It's just the first in the order of which we're talking about things this evening. So diet therapy, specifically the ketogenic diet and some of its less rigid variants. This is typically a palliative option, very rarely curative. So it can completely eliminate seizures in about 5% of people who follow the ketogenic diet, but usually it just reduces the frequency of the seizures and the burden of epilepsy in a person's life. It's been used since the 1920s. We have reasons to think it's very, very safe and has proven to be effective over about 100 years. The goal is to change the way your brain uses energy, specifically sugar, to reduce its tendency to have a seizure. So this is chemistry and biology at its best here. We're taking in an energy substance, an energy source in our food that is changing the way our body's metabolism is working and the way we're breaking down energy sources for use by the brain. And that process, that ability to modify that process based on the foods that we eat, can reduce the frequency or the intensity of seizures. This must be strictly followed. This is something that can be easily undone with a cheat day for all of us that are trying to lose weight. You know, after the pandemic, we have good days and bad days. This is something that must really be strictly followed, because we're modifying the way our body is using its energy sources. And when those energy sources vary on good days and bad days, it's hard to get this body and get our bodies into this new steady state of metabolism. It's also important that this be done together with the guidance of a neurologist and a dietitian. There are important nutritional considerations that must be factored into dietary choices, and your neurologist must also be aware that you're doing this, because it can impact the medications they may choose for you and other decisions they may make on your behalf. Moving into surgical options. So diet therapy is one option for seizures that persist despite medication, and the second are surgical options. And I'm a surgeon. I have many different surgical options to discuss with you this evening. Not all of them include surgery on your brain, which I know is a scary thing to consider, but we're just going to unpack these one by one and go through what they might be able to offer you if you're continuing to live with seizures despite medication. So the first is surgical resection. This is frequently curative. This is the manual removal of brain tissue, which is diagnosed to be the part of your brain where your seizures are starting from. And this can completely eliminate seizures in about 70% of patients who have it. So this is not all patients with epilepsy. This is those patients who have seizures that persist despite being on multiple medications. And of those, again, about 30% of all people with epilepsy, 70% of the patients who go on to have some of their brain tissue removed, and it's important to remember when we're thinking about the removal of brain tissue, that this is brain tissue which has been determined to be essentially causing more harm than good. It's generating your seizures, and it's likely not serving its normal healthy brain functions. And so removing it can frequently be to your advantage, not only with regard to seizure control, but also with regard to memory performance, cognitive performance, etc. The surgical resection of tissue for seizure control has been done since the 1930s, so coming up on about 100 years of history. It's been tried and true, and it's what we call the gold standard, or the measure by which we compare all of our other surgical options against. Newer on the scene is laser ablation. This is also frequently curative, but a little bit less consistently curative, meaning that only about 60% of patients, or 6 out of 10 patients who have a laser ablation for seizure control, will become completely seizure-free. And it has been used in epilepsy with increasing frequency since 2012. So a much newer kid on the block, but so far the data that we have available to us over the last 9 or so years suggests that it has an important place in the toolbox for those of us who treat epilepsy using surgery as a tool. Next is what we call a hemispherectomy, which is also frequently curative, also has been done for many years. This, I believe, dates back to the early 1900s. I can't quote the exact year here. Sorry, I left that out, but it's been done for many years. Perhaps early to mid 1900s. And it's also frequently curative. This is something that is reserved. This is a surgical approach that's reserved largely for children or for individuals whose seizures began in childhood and are related to damage to a certain half of the brain. So frequently related to a stroke in infancy, or a stroke even prior to the time of birth, where the entire half of a brain can become significantly damaged, and that is the side where the seizures are beginning. And if we can disconnect that side of the brain from the normal, healthy, functioning brain, we can improve cognition, memory, school performance, as well as seizure control. And this is also frequently curative, can completely eliminate seizures in up to 70% of patients who have the procedure done. And then finally, the corpus callosotomy. These are finally with regard to interventions on the actual tissue of the brain. We'll get to the next slide, which are more device-related options. But the corpus callosotomy is what we call palliative, meaning that the goal of the surgery is not to eliminate the seizures, but rather to improve the individual's quality of life living with epilepsy, specifically related to whether or not they're falling with their seizures. If they fall with their seizures and they injure themselves related to those falls, these are the folks we know who wear helmets to protect themselves because of their frequent falls and injuries related to seizures. The corpus callosotomy can be a very good option for those folks to consider. So moving now to the devices, these are medical devices developed for use in epilepsy, or originally developed for use in epilepsy, with the exception of deep brain stimulation, which was first used for other indications and now used for epilepsy. But you can see that there are three. These as a group are typically palliative and more rarely curative than the other approaches we discussed on the previous slide. They can achieve seizure freedom rates in the low teens, about 10%, maybe up to 20% for responsive neurostimulation. They've been around a much shorter period of time because of the technology required for their development. The oldest surgical device used in epilepsy is the vagal nerve stimulator. It was FDA approved in 1997. It's been used with great frequency ever since then. We have 20 plus years of its use. And we know very well that it can reduce the frequency of seizures, the intensity of seizures, but does not eliminate seizures in the majority of patients who have the VNS implanted. The responsive neurostimulator, or RNS, is also typically palliative, can be curative or eliminate seizures in up to about 20% of patients who have an RNS implanted. This was FDA approved in 2013. And the goal of RNS, we'll get into this in more detail, but the goal of RNS is to detect a seizure at its onset and to stop it in its tracks, essentially. The third and final device available for use in epilepsy is the deep brain stimulator. It's been used for many, many years, dating back into the 1990s. For the treatment of Parkinson's disease and other movement disorders, has also been used in neuropsychiatric disorders, including obsessive compulsive disorder and others, but was FDA approved for use in epilepsy in 2018. Also typically palliative, reducing the frequency of seizures, the duration of seizures, the intensity of seizures, but can be rarely curative in up to 10% of patients achieving complete seizure freedom with DBS therapy. So surgery for epilepsy is a really exciting field right now. We have new treatment options, as you can tell, going in 2018, 2013, 2012 with the laser that we didn't have now, about 10 years ago. Surgery should be considered as an alternative, just as diet therapy should be considered as an alternative treatment option for individuals who have medically refractory or drug-resistant epilepsy, or simply seizures that persist despite the use of multiple medications. And the goals of different surgeries vary for different patients. The risks and benefits of each of these procedures are difficult to generalize across all of them as a group. And should be certainly discussed with your neurologist and any surgeon who's proposing the use of any of these procedures. The goal of this talk is just to raise awareness around the availability of these options. In the past, patients tried many, many medications, dozens of medications, with many years of poor results, poor seizure control, with surgery frequently being considered a last resort option, only for people who have, really bad epilepsy, whatever really bad epilepsy is. I think everyone living with epilepsy would say their epilepsy is really bad, especially if their seizures are persisting despite medication. But we now understand that the earlier surgery is performed, the better patients do. the more likely they are to achieve complete seizure freedom. And in children, the better the cognitive development, the school performance, memory function can be over time, is enhanced with earlier surgery as well. So let's talk about what we can expect from these different procedures. So surgical cure rates following laser ablation, this is at 2 years. And the reason we choose 2 years is because frequently people will have a period of time where their seizures go away after the surgery, and then maybe they come back, maybe they come back less frequent, maybe they come back different, they can come back the same, they can come back different. So we're really talking about, of everybody who's had the laser ablation for management of their epilepsy, how are they doing at 2 years? We figure 2 years is an important line in the sand to measure how you have responded to that surgery, and that anything shorter than 2 years is probably going to overestimate the benefit, because there can be this kind of dynamic response over time. So you may or may not be aware of an entity, a particular type of epilepsy related to hippocampal sclerosis. The hippocampus is a structure in our brain which can become damaged or scarred over the course of time. Frequently, people who have hippocampal sclerosis will have a history of having had a seizure as a baby in the setting of a fever. We don't know if the hippocampal sclerosis was there to begin with and caused that seizure as a baby, or if that seizure as a baby may have predisposed to the development of this scarred up little hippocampus over time. Kind of a chicken or the egg question that we don't yet understand. But when we see hippocampal sclerosis and the seizures line up as being related to or coming from that little scarred, shriveled up, damaged hippocampus, and we treat it with the laser ablation, we get our best outcomes using the laser. And that's 65% complete seizure freedom when using the laser in the setting of hippocampal sclerosis. The hippocampus is a structure within the temporal lobe of our brain. The temporal lobe is the tissue of our brain. If you go between the outside of your eye and the top of your ear, you're basically covering the area where your temporal lobe lives. So when you have temporal lobe epilepsy, which is a common place for seizures to begin, but it's not related to hippocampal sclerosis, we can achieve complete seizure freedom using the laser in about 50% of patients. And when we use the laser for management of seizures outside of the temporal lobe, especially if there's no identifiable abnormality on an individual's brain MRI, the seizure freedom rate drops to 30%. Now, we may say 30%, you got to be kidding me. But yes, we wish that number was higher. There's many of us around the world doing research to try to figure out how to drive that number higher. But the fundamental point to take away from this is that 30% is a heck of a lot higher than 0%. If 0% is the likelihood of having continued seizures, the likelihood of achieving seizure freedom with continued use of medication alone, and then we offer something that has a 30% chance of completely eliminating the seizures, we think that is a conversation worth having. Not necessarily that the laser is the right thing to do, but we at least think that conversation is worth having. So let's talk a little bit more about laser ablations. This is a minimally invasive alternative to traditional resective surgical strategies. So like I said, since the 1930s, we've been taking tissue out of people's heads, parts of people's brains out of their heads for the purposes of seizure control. This is similar conceptually to that, where the goal is to completely eliminate the seizures by treating the tissue that we believe the seizures are coming from, but instead of having to have the bigger surgery, the bigger scar on the scalp, the bigger window of bone removed, the removal of tissue, and then sewing everything back up with a hole where the tissue previously was, we're now able to use this laser in a minimally invasive approach using a different strategy to achieve the same goal, essentially. The goal is what we call cytoreduction of the seizure focus. The seizure focus is the part of the brain where the seizures are beginning from. And cytoreduction is just the reduction of those cells, whether it's the reduction by removal or the reduction by burning to the point of it's no longer being able to generate a seizure, the goal of that remains the same. This laser ablation takes advantage of very advanced imaging technology called real-time magnetic resonance thermometry, and we'll talk about that here on this slide. So magnetic resonance thermometry is the ability to track the spread of heat through an individual's brain. So you see here in the top panel and the bottom panels exactly what we see at the time of surgery. In fact, I did one of these earlier today. I saw this earlier today in my patient. And what we see is this heat map of damage. This is on purpose damage, of course, to the tissue where the seizures are beginning from. And we turn on a laser. The laser is essentially a hot light on a stick. And we turn the laser on and it releases thermal energy from its light on the end of this long probe, which we take great care to get exactly where we want it to go. We turn on the light, heat comes out from the tip of the laser and it spreads. And every 8 seconds, this is a procedure which is done with the patient actually within the bore of the MRI machine. The MRI machine is on, capturing images in real time. And we're able to see how the heat is spreading through the tissue of the individual's brain every 8 seconds. And you'll see the yellow line in the top left corner and the blue line in the top right corner. And those are lines that are estimating the damage or approximating the damage using a complex physics equation to tell me, or the surgeon performing the surgery, what tissue has seen enough heat to be damaged. That is within the yellow line. So anything outside of the yellow line is safe. It has not seen any heat. It should not receive any damage following surgery. The blue line is typically within the yellow line, and the blue line is an approximation of the tissue that has seen sufficient heat to be rendered no longer able to generate a seizure. So it's essentially dead if we want to think about tissue dying in response to being damaged by the laser. Of course, we do this in a way that we make sure that that tissue is safe to be damaged in that way. But when we do this, we want our target, that we want the tissue where the seizures are starting from to be inside the blue. And we want the tissue that we don't want to damage, maybe the part controlling your language or the part controlling your motor function. We want that to stay outside of the yellow. And the yellow line and the blue lines both update every 8 seconds, and we can see how that heat is spreading and stop the ablation once sufficient heat has been distributed. And you'll see the bottom panels are just other slices showing that information in a different way. So this laser technology has been a great addition to the surgical toolbox because it makes us able to treat deep lesions or parts of the brain where seizures are starting, which would require going through normal healthy brain tissue in order to arrive at that tissue for purposes of seizure control. So you notice in the picture here on the left, this is a patient that was treated during my fellowship, or excuse me, no, my residency training. And you can see the laser probe is this little stick here coming into the brain tissue. And you can see that the laser probe is going down into this deep part of the brain we call the insula. And it's going through this normal healthy brain tissue overlying it. In order to arrive at the insula, some of this normal healthy brain tissue would have to be damaged in order to get to that tissue if we were going to manually remove it. So our ability to use the laser allows us to preserve the function of the overlying normal healthy brain tissue and target the deeper tissue for purposes of seizure control. So moving now to the use of responsive neurostimulation, or RNS, it goes by the brand name of NeuroPace. The laser companies, if you have any interest in looking it up, the two laser companies available for use in epilepsy are Visualace, which is a Medtronic subsidiary, and the NeuroBlade system through the Monteris company. feel free to Google any or all of those. But moving now to responsive neurostimulation. This is a great treatment option for individuals who have seizures coming from a part of their brain where damaging that part of the brain would cause problems. So this could be seizures coming from where your speech comes from, or seizures coming from where your motor function comes from, or seizures coming from where you form memories or remember language or other important functions like that. So the brain tissue stays in, doing all of its normal healthy brain functions and continuing to have seizures. And we implant a device called a responsive neurostimulator, which is able to record in real time your brain activity, and over time is able to be trained. It captures that, it records it on, you'll notice that there's this little battery pack that gets implanted into the skull here, and it records that, and your neurologist is able to access that data, and over time, train or teach the device to recognize the electrographic pattern or the fingerprint of your seizure activity. And when it is able to effectively learn that, it can provide a small pulse of stimulation, which aborts the seizure or prevents it from developing into a seizure. The targets can be either deep, similar to what we might use the laser to get to, or they could be superficial over the surface of the brain. There's two different ways we can record and stimulate the brain activity using this device. I think I said all of that. So this is fundamentally new technology. We talked about the laser being kind of a new, minimally invasive way to do what we've always been doing with surgical resection, but the responsive neurostimulator is really fundamentally new technology in that it allows us to treat seizures coming from a part of the brain which previously we would not have been able to offer surgery to, because the risks of damaging that part of the brain outweigh the benefits of controlling seizures coming from there. Sorry, this slide is a bit more wordy than I intended it to be, but essentially I think this is saying what I previously said, where the system records the electrical activity, provides a small pulse of stimulation, and it does something for your brain similar to what a pacemaker or a cardiac defibrillator can do for the heart, where it can detect that abnormal rhythm and provide that pulse of stimulation to kind of shock you back into a more normal electrical pattern coming from the brain tissue. This can be used for treating seizures coming from a single part of the brain or up to two different parts of the brain. We usually reserve it for people who have seizures coming from one part of the brain, just because our results tend to be better in that situation, but it can be used for individuals with seizures coming from up to two different parts of the brain as well. This is just a graphical representation borrowed from the NeuroPace company, because I think they show this very nicely about how the device works. The peach color is kind of normal, healthy brain activity. It's recording that in real time. The blue is the unusual or the very early onset of seizure activity. It can detect that and recognize it as abnormal based on how your neurologist is able to train it to do so. This is artificial intelligence in medicine at its best, in my opinion. And then it will provide a small pulse of stimulation, represented as purple, where it can kind of abort or stop that abnormal activity in its tracks, and then the brain will resume normal, healthy function thereafter. This all happens within just a few seconds, or even shorter than that, for the detection of the unusual activity. So technically, responsive neurostimulation is considered a palliative surgical option because the brain continues to have seizures. They're just being treated locally through this electrical stimulation. So it's not curative because the seizures are continuing to happen, but they're just getting better controlled using this device. However, what's really interesting is that some patients do actually have a cessation of their seizure activity after a few years of RNS. We don't completely understand why that happens. We use this kind of hand-waving term called neuromodulation, which is where the provision of electrical stimulation to the brain can impact the way the brain communicates with itself over time, and can just kind of calm the seizures down over time, so that the seizure activity can stop. Again, rarely, about 15% of patients, maybe up to 20% of patients with RNS for multiple years, but we do certainly see that. And then this is just another graphical representation, just showing that the seizure response rate, this is individuals who had a favorable response following implantation of RNS, and it is cumulative over time. So people, 44% of patients will be responders at 1 year, 53 at 2 years, and then all the way up to 72 at 7 years. Suggesting probably my way to make sense of this information is probably 2 primary contributing factors to why it improves over time. Seizure response rates improve over time. The first of which is that the interaction with your neurologist will continue. So every few months, you'll go to your neurologist like you currently do. They'll check your device. They'll see what events are being stimulated, and they can tweak the stimulation parameters so that the device is able to capture more and more events over time. So the device is actually getting better at detecting the seizure events because of this back and forth pattern that you and your neurologist will have in the neurologist's ability to train the device to recognize the events as abnormal. The second is this hand-waving term of neuromodulation, which is where we believe this provision of stimulation is kind of modulating the connectivity patterns of the brain, and it may just be kind of just getting better control of the seizures over time for reasons we don't completely understand. Moving now to the third device for use with epilepsy is deep brain stimulation. This is an alternative treatment option for people who have multifocal, poorly localized, or rapidly generalizing epilepsy. So this is for people or can be considered for people who are not candidates for other treatment options, but continue to have disabling seizures and DBS. Deep brain stimulation can be used to target deep structures of the brain, as the name suggests, specifically within the thalamus, which are believed to be sort of central relay hubs within the brain, and can be effective at treating patients with seizures coming from multiple different parts of the brain, seizures coming from a part of the brain that's really difficult to pinpoint, or poorly localized seizure onset, as well as rapidly generalizing seizures, meaning within the first few milliseconds, the seizure is kind of everywhere throughout the brain, suggesting that there's something driving that rapid generalization, and targeting the seizures more deep within the brain, specifically within the thalamus, is better likely to get control of the seizures rather than targeting them at their specific onset location. This has previously been used for many, many years in Parkinson's disease and essential tremor, and applications are now expanding to include epilepsy and other disorders. Finally, for purposes of completion, I'm sure many folks on this call are familiar with vagus nerve stimulation. This is a device implanted into the neck. It does not require anything being done to the brain itself. It's also used to treat poorly localized, multifocal, or generalized seizures. This is a good option to consider for people who have persistent seizures that are generalized in onset, meaning that the entire brain demonstrates seizure activity simultaneously, in contrast to focal onset seizures, where a specific part of the brain starts to have the seizure, and then that seizure may or may not spread to include other structures of the brain as well. It provides electrical stimulation to the vagus nerve in the neck, requires a small incision off to the side of your neck. Then a battery generator lives underneath your collarbone. It's been used with good effect since the mid-1990s, and patients can enjoy a significant reduction in their seizures, but very few of them, potentially up to about 10%, can become completely seizure-free with this technology. And like we discussed for RNS, and to some degree DBS as well, the response rate improves over time, sort of capturing that notion of neuromodulation. that we don't understand, but seems to be very real and reproducible across these different neurostimulatory treatment options. So it's important to notice, and I'm going to wrap up here and open it to questions, but a few final slides on the idea of epilepsy centers. Not all epilepsy care is created equal. The National Association of Epilepsy Centers is a group who kind of grades the level of care provided at a certain hospital or by a medical group. Level 1 epilepsy care is where epilepsy care is provided by emergency medicine physicians or primary care providers with no specific expertise in neurology or epilepsy. Level 2 epilepsy care is where seizures are managed by general practice neurologists without subspecialty training in the management of epilepsy. And level 3 epilepsy centers is where epilepsy care is provided by neurologists with specialty training in epilepsy. They also provide a range of medical, neuropsychological, and psychosocial services specifically designed for patients with epilepsy, including some fancy imaging availabilities, some social work services available for people with epilepsy, and also there's a certain minimum requirement of epilepsy surgeries to be performed at a level 3 epilepsy center as well, although that minimum number is relatively low. A level 4 epilepsy center is where epilepsy care is also provided by neurologists with specialty training in epilepsy, and they offer more specialty services, kind of additional bells and whistles above and beyond the level 3 centers, but also minimum requirement of epilepsy surgery, which is significantly higher than the level 3 centers as well. So the National Association of Epilepsy Centers has published guidelines on when to seek care at higher level centers. And they really have 2 lines in the sand, if you will, for when to seek higher levels of care for your epilepsy. The first of which is that if seizures have not been brought under control after 3 months of care by a primary care provider, that would be a family medicine physician or pediatrician, then further care should be sought by a neurologist. So that's transitioning from a level 1 to a level 2 center after 3 months if seizures persist. If seizures continue to persist for an additional 12 months under the care of a general neurologist, meaning someone without additional subspecialty training in epilepsy, patients should be referred to a level 3 or 4 epilepsy center for evaluation by an epileptologist, who is a neurologist with at least 1 additional year of training in epilepsy, if not 2 years of additional training in epilepsy. The National Association of Epilepsy Centers has a great Find an Epilepsy Center tool on their website. You can just Google National Association of Epilepsy Centers and navigate to the tool on their website. I just put in Chicago and maybe the downtown zip code, I can't remember. And these are the locations that came up in the Chicagoland area of level 3 and level 4 epilepsy centers. And then there would be contact information for each of these, of course, available on the website. And I'm also happy to announce my own personal educational platform, which I've been developing over the last 6 or 8 months or so, called epilepsyacademy.com, as well as a YouTube channel where I'm posting short educational videos. I like to call them knowledge nuggets. We try to keep them under 5 minutes if possible, usually about 3 to 5 minutes. And the goal is just to provide fact-based information in epilepsy delivered to a non-medical audience, just to equip you with information so that you can ask questions and advocate for yourself or a loved one. So with that, I will open it up for questions.
Thanks, Dr. Bandt. That was great. I wanted to know if you could go back to that slide, a couple slides towards the end. You had a really great timeline as far as when a person should move from the primary care provider to level 1 to level 2, 3, 4.
This one here?
I think this is such important information. I just want to make sure people really get a hold of this, because I think this is where, I know you and I have talked in the past about the 12 months turns into years. And people are still on that same sort of hamster wheel, and they're not getting out of that loop. So I think this is extremely important. So I'm really glad you brought this up.
Yeah. In fact, the patient I referred to operating on today is exactly that that case where they were referred to me in their mid-50s and had seizure onset in their mid-teens and had never been told about surgical options for epilepsy. And hopefully we did something to help them today. So I wish this information was more readily available. That's why I do talks like this, and I build up the Epilepsy Academy website is to get this information out to people who need to know it.
I guess there's a question about some of the semantics of some of the epilepsy centers. Is Payless Hospital now going to be part of Northwestern?
Yeah, that's a great question. Yeah, so stay tuned. I don't actually know what's going to, so yes, Payless Hospital is going to be part of NM. I don't know when the transition will unfold. I believe we're going to start having epilepsy specialty services at Payless this fall, if I remember from my last meeting on that correctly. So, but that's obviously going to take some time to build. It won't necessarily reach any level 3 status right away because we do have to build that up a little bit, but it will be under the NM umbrella and it will be NM providers providing the care locally at Payless, and services should expand there over time for sure.
Great. And then also for anyone who would like to make an appointment with you, Dr. Bandt, what's the best way, or is there a website that you would like to share?
Yeah, of course. The best number to get me would be the neurosurgery line at Northwestern, which is 312-695-6200. You can call that line and just ask for an appointment with me, and whoever you get should be able to point you in the right direction.
Hi, Dr. Bandt. My name is Parth. I had one quick question.
Yeah, of course.
I'm kind of new to neurology. I've co-founded a startup, and so I'm just still trying to learn the landscape. Can you kind of help me understand what you think are the barriers for why people are getting stuck in this cycle and not getting to you quicker?
That is the $1 million question, Parth. I would love to talk to you more about that offline.
Okay.
It is
All right.
Multifactorial, complex, and not completely understood, I think. But there are some guesses, and I think there's some low-hanging fruit to try to address that. Okay. So I would be happy to discuss that further with you. If you go to Epilepsy Academy, there's a contact form, and that will get you to me, and we can talk about that more offline. But that's a great question.
I appreciate that. Thank you.
Yeah. Thank you again for your time, and we look forward to connecting with you on epilepsyacademy.com as well. So thank you.
Great. All right. Thanks, guys. Take care.
Thank you. Have a great night.
Thanks. You too.